Hi everyone, and welcome back to the Chemist Couple podcast with your hosts Jess and Lee. We are both clinical pharmacists who work in GP practices in the northwest of England. The aim of our podcast is to provide evidence-based advice, personal experiences and create awareness around long-term health conditions. We hope you enjoy the show. Okay, so this week we are going to be discussing type 2 diabetes. The reason why we've chosen this is because it's something that we've discussed in a lot of the podcasts over the last, couple of months, because it is one of the biggest long-term health conditions, or the most common long-term health conditions in the UK.
Yeah, I think a lot of people don't give it the credit it deserves, really.
Yeah.
A lot of people, as you'll find out in a minute, have been diagnosed with type 2 diabetes. A lot of people are living with not being diagnosed, and the complications that it can do with and have are so serious.
Yeah, I know. I think it is because it is probably so common. Everybody listening to this probably knows somebody who has been diagnosed, or someone who's listening to this could be diagnosed with type 2 diabetes, and because of that, yeah, like you say, the severity of the condition is it just diminishes, doesn't it? When something becomes quite common, you don't really think about it as being something that can do some real damage.
Exactly.
But like you say, we will discuss that it potentially can.
Yeah, I like to say before, these are our own opinions, and like always, you should always seek medical advice from your local healthcare provider.
Yeah.
Before doing so. But yeah, I mean, type 2 diabetes is something that we've looked at for a while since we've been qualified, and the more you look into it, ironically, the less you know. And the reasons behind how it develops and how we manage it has changed even over the 5-6 years we've been qualified.
Yeah.
And we'll touch upon it, I think, slightly on this episode, and then maybe next week when we do the treatment.
Yeah, definitely. I think we did discuss this morning as well about just how far we've come in terms of knowing about diabetes, just within like you say, the last 20-30 years. The difference is huge, and I think we've still got a long way to go, like we will discuss in this podcast and the podcast after this. But we'll just try and go through in this podcast what are the clinical symptoms of type 2 diabetes, what are the long-term complications of type 2 diabetes, the statistics as well about who's affected by type 2 diabetes.
Yeah.
And then in the podcast that we will release next week, we're going to be then discussing just the management of type 2 diabetes. And we thought that it might be better to do that because the management of type 2 diabetes may not be relevant to some people. If you haven't got type 2 diabetes, you don't really need to know how it's treated. However, if you or someone has got type 2 diabetes, it might be worthwhile listening to that podcast.
Yeah. So a lot of the stats that we're going to start off with come from the year 2022-23. Diabetes UK are probably the biggest provider of stats that we've used.
Mm-hmm. That's also the biggest provider really of information for anybody looking about just looking to read up more about type 2 diabetes. We will actually give that website to patients who are newly diagnosed because it is really useful.
Yeah. So one of them is that in that year, £10 billion was spent from the NHS on diabetes as a management group. So that's about 10% of the annual budget. And 80% of that 10 billion was being used to treat complications of diabetes. Mm-hmm. So not even just the actual blood sugar management, it was all the complications that come from around it, which is quite scary.
It is, yeah.
And then there was another stat saying that give or take 25% of hospital bed occupancy is related to someone who's diagnosed with diabetes. So it's an ever-growing condition, as you'll find out.
Yeah.
And in terms of prescription items, again, there's a bit of controversy around it because a lot of people misuse diabetic medication, over-order insulin, for example, have it stockpiled. But in the 2022-23 year, 66 million prescription items were provided on the NHS.
It's crazy.
Which is an increase of 17.5 million than the decade before.
Yeah. So just in that alone, it shows that although we're beginning to know more and more about type 2 diabetes, more and more people are being diagnosed with it. Now, obviously, you could argue that is because we do know more about it, and so it's easier to diagnose and things. But on the other hand, and probably from experience, that we have working in primary care, it probably is that it's just that more and more people are being diagnosed with it, and it's not due to the fact that we know more about it. It's probably a mixture of the two.
Yeah. A lot of a lot of things like that in medicine now, aren't they? In terms of our awareness is increasing, but our health, I think, is declining in general.
Yeah.
But I think that brings us on nicely to prevalence. So how common is it? So at the moment, there's approximately 4.4 million people in the UK diagnosed with diabetes, of which 90% are type 2, so give or take around the 4 million mark. And they estimate that 1.2 million are living in the UK undiagnosed with type 2 diabetes.
Yeah.
Yeah, that's scary, isn't it?
It is scary. It also can now occur in all age groups. So if you look back to, like we were saying, a few, like 10 years ago or 15 years ago, it used to be known as adult onset diabetes, and it was also known as non-insulin dependent. Now, the reason why we don't call it that anymore is because actually you can get it at any age group, and we're finding that more and more young people and children are being diagnosed, which is terrifying because if you look at the studies in children, if you are diagnosed with type 2 diabetes at a younger age, then your outcomes and the complications that you can develop are more serious, and it leads to a higher mortality and morbidity rate. So it is important that we are educating, especially our children, about this condition, because if you do get it, then your outcomes are going to be worse.
Yeah, so that accounts for about 3,600 people under the age of 19 being diagnosed with type 2 diabetes. But like you said, years ago, it was a case of your age would determine what diabetes you had. So if you were under the age of 18, normally it was just type 1 straight away. Now we know that there's instances where it can be delayed autoimmune until later on in your 20s, 30s, etc.
Yep.
And if you were in your 40s, 50s, it was normally always type 2. And we can't just apply them general rules anymore. We have got to look into it, and that's why people are increasing in the awareness and all these tools are out there.
Yeah, and it is a global issue. So I know that we discussed this, that it is an issue within the UK, which it is, but it is also rising rapidly across the globe.
Yeah,
as well.
It is. So background of type 2 diabetes and diabetes in general, you did touch upon the name change.
Yeah.
So yeah, non-insulin dependence was a common cause, but now we know we can treat it with insulin, and that's quite frequent for a lot of patients now. Adult onset, we just debunked that in the fact that a lot of people under the age of 19 are being diagnosed with it. But diabetes, as a definition, is persistently raised hyperglycemia, which is high blood glucose, isn't it? I just said that the wrong way. Unnecessary words, but that's what it is. And we'll go on to the thresholds later. But in this context, we're going to say a random blood glucose of 11.1 or more. Yeah. And then in terms of type 2 diabetes, it's mainly due to a combination of a relative insulin deficiency and or insulin resistance. Yeah. So, do you want to talk about how that comes about? Or what we've been looking into in terms of the model? Yeah. So years ago, it was just a case of you eat more sugar, your blood sugar rises, it does lead to all these complications, it can damage, etc. Then I think it was about 2008, at the top of my head that is, there's a twin cycle theory, which is due to fat accumulation within your liver. So the idea being that if you ingested too much fat, each individual person has their own fat threshold. So for example, that's why it means certain people can be diagnosed with type 2 with having a healthy BMI. Yeah, because of their threshold may be lower. So for example, you could get it even though you're a healthy BMI and someone who's a lot heavier couldn't. Yeah. And the idea is that the liver is infiltrated with fat. Eventually, there's more complex processes in it, but then it would lead to an increased formation of VLDL, like fat particles coming out of the liver. That will then infiltrate the pancreas. And then that fat within the pancreas can then de-differentiate the beta cells of the islet of Langerhans, and then that can lead to a rapid reduction of insulin production. Yeah. And the studies sort of coexist with this in terms of when you've had a calorie restriction, it has improved insulin production, insulin resistance is sort of resolved as well. So that's the theory behind it. Yeah. The other one, like you say, insulin resistance, is... I saw it explained as like you having, say for instance, a coffee. So obviously coffee contains caffeine, and our bodies will have a threshold about with how much caffeine we need to produce a response. So usually it's like making you more alert, more awake. When you start to have caffeine more and more often, your threshold becomes higher, so you tend to need more caffeine to produce the same response. And it's sort of similar in the way with insulin. So
the more and more insulin you produce. So if you are having a diet higher in sugars, you need to produce more insulin. The more insulin that you produce, well then it means that your body then kind of becomes desensitized to it. So to produce the same response in terms of being able to take the glucose from your blood into your cells, you'll need a higher amount of insulin. So that's how you get the insulin resistance. It's obviously more complicated than that, but that's how maybe it's a nice way to explain it.
And then there was that way we looked at this morning where it was due to the fat formation, and then that deactivates proximal insulin release, and it just got into another level of complexity that I've never looked at before.
Yeah, and I think it's important to know as well that when we think about insulin, we automatically think about glucose or like the metabolism of carbohydrates. However, glucose is involved in metabolism of fats and protein as well. So if you're eating excess carbohydrates, if your body doesn't need them carbs, it will store it as fat. And so and it's all because of
it's all an interconnected pathways. The same way amino acids will trigger insulin release to some extent. And I've always said this, whether bodybuilding in the future will lead to higher rates of diabetes, I don't know. That's always something we thought of. But yeah, I mean, it's always advancing in terms of our understanding, isn't it?
Yeah, but the two main ways is to developing type 2 diabetes is insulin resistance and insulin deficiency. And you can have either or you can actually have both.
And one thing that's changed with diabetes, especially type 2, is it isn't a life sentence. We will touch upon it next week, but you can go into something called remission, which is where you're clinically not diabetic.
Yeah.
And that's mainly been facilitated through diet and lifestyle.
I know, and we just discussed then in terms of, we'll go on to the complications of it, but the complications of type 2 diabetes can be quite serious.
They are.
And the fact that this condition is reversible and you can go into remission, it's sad that maybe we were discussing maybe it's because the people don't get the support that they need, or there's not the correct information out there of how to actually go into remission. But the fact that you can do is it's crazy.
I think it's because a lot of people coexist with diabetes at the moment, and whilst they're not having a serious complication, I just think everyone thinks you'll get by. And there will come a time when there'll be cohorts of patients who will have serious complications at one time, and then that will really be when the penny drops. But I think we should go on to... Well, do you want to go on to complications?
No, I just was like, we'll discuss that in a bit.
So causes and risk factors of type 2 diabetes. One of them is, one thing that we touched upon, is obesity and physical inactivity. Yeah.
So that accounts, so 90% of people who are diagnosed with type 2 diabetes are either overweight or obese. So that is the number one risk factor or cause of type 2 diabetes. And like you say, it's all to do with the accumulation of fat within the body. And then
that's one theory, isn't it?
Yeah.
And it seems to be gathering a lot more pace, and there's a lot more evidence around that theory.
Yeah.
And then also I want to touch upon family history. So you are 2 to 6 times more likely to develop type 2 diabetes if you've got a family history. Now, if you've got one parent who has it, it's a 15% increased risk, and if both parents, it's 75%. Now, in terms of, it's one of them things, is it down to the genetics, or is it due to the nature that they're being brought up in? So if you are being brought up in an orexigenic environment, all you know is excess calories intake. Yeah. So is that due to that, or is it due to abnormal fat thresholds? Yeah. So I think it's quite hard to rule out. It is, and the only thing that I would say is that they have done studies with sets of twins on the development of type 2 diabetes, and it is found that if one twin has type 2 diabetes, it doesn't automatically mean the other twin does. So it's not a genetic. So it's more to do with nature as well. Yeah, that's what it basically was showing. Is that obviously there are genetic factors within it, but it is like also to do with the environment that you're brought up in. Yeah, and now we go to diet. So that's a big thing that's changed drastically over the last 30, 40 years with ultra processed food. Yeah, and access to food as well. And sadly with advertisements, it is more appealing to go for fast food than a natural organic food. But we have diets that are lower in dietary fibre. We have diets that are higher in high glycemic index foods, which is basically a quick release of sugar within the system. Yeah. All of these are going to amount to persistently raised blood glucose and diabetic, well, tendencies anyway.
Yeah. And then also, did you want to discuss any more?
I was just going to keep going through them.
Yeah, okay. And then we've got ethnicity. So people of Asian, African and Afro-Caribbean ethnicity are around 2 to 4 times more likely to develop type 2 diabetes.
And they will develop it at a lower weight threshold than that of a white ethnicity.
Yeah.
Or white population. So that's why when you look at the BMI, I can't think of when it was changed, even though we'd done a podcast not long ago, but that's why they did change the boundaries. So obese was classed as a BMI of 30 or more. It was reduced to 27.5 in other ethnicities, because that's when they develop severe complications or these metabolic disorders.
Yeah. I think, correct me if I'm wrong on this, but I think the ethnicity risk factor is more to do with the genetic makeup of those populations. I think that's what I read in a study. Obviously,
I've never really looked into why it is between different ethnicities, but it could be diet. I mean, it's quite hard.
I think that,
something I need to look into.
It is. Also a history of gestational diabetes. So gestational diabetes is diabetes that is that comes about onset when you become pregnant. So women who've had a previous history of gestational diabetes are 7 times more likely to then develop type 2 diabetes in the future. And then children born to women who've had gestational diabetes are 6 times more likely. That was one of the stats that really shocked me, because it's a huge increase, isn't it?
It is, but a lot of things are influenced during,
because your hormones are changing a lot at that time, which is obviously insulin is a hormone.
Yeah, and we've watched the podcast and a webinar for, I can't think who it was, the Royal College of Physicians on breastfeeding.
Yeah, we did. We're going to do a podcast on that probably.
Yeah, and they were saying that the microbiome's made up at the age of 3 that you're going to have for the rest of your life. So you can see how these small changes, even in pregnancy, are going to influence your health as a child. Yeah. Let's go into something that we know a lot of, drug treatment. Yeah.
So certain drugs can actually cause hypoglycemia. So the main one, or the one that probably a lot of people will associate it with, is corticosteroids. So prednisolone being the main one that's used. So just bear in mind that if anybody is on long-term steroids, you should be getting your HbA1c checked, which is a blood test to measure your blood sugars basically. Some patients will also be given a glucose monitor that they can use at home, so it'll just be a finger prick test, and then they can test their own blood sugars if they're on long-term steroids. Just so that you're aware of if it is having an effect, because it may not affect everybody who's also on long-term steroids. Then other medications, so statins.
So we start statins in a lot of patients, especially with diabetes, for prevention of cardiovascular disease, like stroke, heart attack, etc. So it's ironic that it can lead to high blood glucose, but I think the benefits outweigh the risks on that one. Yeah. And then also we've got thiazide diuretics, which not many people tend to use. It's normally 3rd, 4th line in terms of 3rd line high blood pressure. Yeah. So it's not something that should cause a lot of problems to a lot of people. But there was a time when benzoflumethiazide was prescribed for a lot of patients, especially with ankle edema. So with these patients, I normally get the HbA1c monitored every year, or 6 to 12 months, because that's normally missed. Yeah. And some of them might develop diabetes from that.
Yeah. Polycystic ovaries syndrome, so PCOS, is also a risk factor for developing type 2 diabetes. Yep. And then metabolic syndrome, so that's a group of different conditions that a patient may be at increased risk of. So patients who've got high blood pressure, dyslipidemias, fatty liver disease, central adiposity, and then a tendency to develop thrombosis. So if you it's a bit of a weird one, metabolic syndrome. I need to look more into it, but if you have that, then you are at an increased risk of also developing type 2 diabetes.
Yeah, it's just an umbrella term for all risk factors mainly. Yeah. That's how I define it. Yeah. But so they're the main causes and risk factors. And then the next thing we wanted to touch upon was prognosis, in terms of what happens if you do have diabetes, what's the chance of having a normal life, in terms of management, etc.
Yeah, so like we said before, with type 2 diabetes, it doesn't mean that you're going to be type 2 diabetic forever. If you do still measure or change some of your lifestyle
characteristics.
Yeah, you can go into remission.
You can.
And people who are on optimal management of their type 2 diabetes can live a normal life, so the same life expectancy as they would if they didn't have type 2 diabetes. But we were discussing this before, and we were saying that a lot of patients who do have type 2 diabetes, unfortunately, are not very well managed or well controlled.
Yeah, and I think it's because they don't understand the severity. I think that's literally what it is.
Yeah.
Obviously, every year they go for a review, 6 to 12 monthly, they'll get a number, which will go on to what HbA1c is in a moment. They'll get a number and go, oh, okay, it's a bit better than last time, but they're a bit better than last time, is still at a high risk.
Yeah.
And it's such a severe condition in general.
Yeah.
I think people just need to take more accountability with it.
Definitely. Because also if you are insulin deficient and do have type 2 diabetes, then it gets worse over time. So the condition doesn't often stay stagnant or get better without intervention. So it will just progress. So it's important to, try and take heed of whatever, what you're doing.
So let's go into complications. Like we said at the very beginning, 80% of the diabetic budget, which is give or take 8 billion, is spent on treating complications of diabetes. Now, there are two broad categories. There are macrovascular, meaning anything related with the cardiovascular system, and then you've got microvascular, which has a whole host of things as well.
Yeah.
So in terms of macrovascular, you've got, on average, it's a 2 to 2.5 times more likely to have a heart attack, heart failure, or a stroke than those who aren't diabetic.
Yeah.
And that's normally over a 5-year period, but there is a big risk.
Yeah.
And then peripheral arterial disease, which is basically blockage of the peripheral arteries, that will be present in 50% of people who have diabetic foot.
Yeah.
And for those who don't know what diabetic foot is, it's a lack of blood supply, which can lead to effectively amputation of the foot. Now, in 50% of patients, it's peripheral arterial disease. In the over 50%, I think, I'm just going to assume this, it's due to sensory loss in the peripheral nerves. So that could be you lose like sensory information from that nerve, and then you've got a stone in your shoe, for example. You then walk days, hours, etc. with that stone. It can then lead to an open infection, osteomyelitis, which is common, and then that can lead to amputation. So it is very severe, and that's why you should go for your foot checks every year.
I was going to say, yeah, the NHS offer foot checks for everybody who is diagnosed with type 2 or diabetes, to basically check the functioning of your feet, to make sure that you have got sensation there to prevent, hopefully, any of that from happening. So yeah, that's macrovascular. So it accounts for 50% of deaths, actually, CVD. So it could be a heart attack, a stroke, like you say, and that's 50% of people with type 2 diabetes will die from a complication that is macrovascular in nature. It is scary.
The next broad term is microvascular. So one of them that always sticks out for me is the retinopathy, which is eye problems basically. And about 7% of those who are newly registered as blind is due to diabetes, well, type 2 diabetes. And it is the leading cause of preventable sight loss within the UK. Again, there's another national screening programme for diabetic retinopathy. It's something that I would advise anyone to go through, because it's saying about 25% of people with type 2 diabetes will develop some form of retinopathy. And I think I read another study saying that if you have diabetes for 20 years, it then goes up to 2/3 of that population will have some form of retinopathy. So there's only 1 out of 3 that won't be affected over a 20-year lifespan. Like it
is a large number.
It's one thing I couldn't live without.
I know.
Sight is vital.
Yeah.
If you've got it, and especially then lose it.
Yeah.
Through something that's preventable.
Of course. Another microvascular complication is kidney disease. So CKD and end-stage renal failure type 2 diabetes is the leading cause of this in the UK, which it's just crazy. So obviously if you have CKD, which is chronic kidney disease, that can affect a lot of different things. It can affect medication dosages, it can increase your risk of developing infections, just generally.
So cardiovascular
risks, and then obviously end-stage kidney disease is then at the point where you probably need some kind of like renal replacement, so dialysis and things like that, which that in itself, is you have to go for dialysis maybe 3 times a week. It can disrupt like everything in your life.
It's a blessing that we can treat them.
It is,
but
yeah,
it's a hindrance at the same time. You've got to get fixtures put in it.
Yeah. And obviously,
you'd like to go
type 2 diabetes is the leading cause of CKD and end-stage renal failure in the UK. Then you've got peripheral neuropathy, which we did just discuss then, which is the loss of sensation at the peripheries.
Yeah, it can lead to pain, burning sensations, and then I think it affects up to 50% of type 2 diabetic patients anyway. And then that can lead to persistent chronic pain, if I can get my words out.
Yeah. And then the last microvascular one is autonomic neuropathy. That, I think this is a lesser known one, and I feel like it's one that we don't really get taught. We do get taught.
I wasn't really aware of it.
Yeah,
I knew of the symptoms of it, but I didn't class it as autonomic neuropathy.
The only reason I know more about it is because I had a family member who had type 1 diabetes, but the manifestations and the complications are similar, and they had this, and it really affected their life because they had gastroparesis quite bad, and it was making them feel ill. They had really severe diarrhea. It can also cause things like postural hypertension, which is like a drop in your blood pressure, which can cause dizziness. You can collapse. Yeah. I think it affects also the ability of your body to detect like hypoglycemia, which could be like, it could be catastrophic if you couldn't detect that. So
it affects all systems, doesn't it? Sexual dysfunction, erectile dysfunction.
Yeah.
There's a lot of things.
So, and all of these things that we're discussing, the complications, are a result of poorly controlled type 2 diabetes. So that's why it's important to try, if you are diagnosed with it, to try and change, your diet and your lifestyle in order to not develop these complications.
Yeah. And I mean, you may never get them even if you have poorly controlled. Yeah. That's a lottery of health, isn't it?
Yeah, it is.
But I'd rather try and prevent something and screen for it.
Yeah.
Other things, diabetic foot we've discussed. Then we've got psychosocial, so depression. That's with a lot of chronic conditions in terms of it does consume your life, basically in terms of management, monitoring, the fact of the inability to do certain things, so you can't go out for a meal and just eat certain things that other people would have without taking a care for it. So there's all these things. Reduced life expectancy, that's the one that always gets me. Yeah. And it's up to 10 years, so it doesn't really give you a figure. Yeah. But the idea of reducing your life for something that's potentially preventable is scary.
Yeah, it is.
And then one of the things I just got this stat before, to draw your attention to how serious the complications are. So this is on a weekly basis. Diabetes accounts for 184 amputations, greater than 930 strokes, 660 heart attacks, and 2,990 cases of heart failure every week.
It's crazy.
And when you have a stroke, for example, he's had a stroke. Depending on what part of the brain's been affected, that can completely disable you going forward. Heart attacks, again, depending on the type of heart attack, completely disable you. Again, it's all a lottery, but I just wouldn't fancy being in that raffle, would you?
No, you wouldn't. No, you wouldn't.
So what symptoms should you look out for?
So there's quite a few, and it's important to note before we go through the symptoms that if you may have one, you may have a couple, or you may have none. So it depends. And
it doesn't necessarily mean it's type 2 diabetes. A lot of these will have shared symptoms with urinary tract infections, sexual transmitted infections, etc. Yeah.
So the first one that we'll discuss is excessive thirst, which is also known as polydipsia. The reasoning behind this is just because when there's excess glucose in your blood, your kidneys just need to filter it out, and whenever you've got glucose, basically your body is trying to dilute the glucose, so it just pulls water out your body.
That's basically, it pulls it from the cells.
Yeah, it pulls water, so you will be more dehydrated because you'll be going to the toilet more, so that's the second symptom, polyuria. So if you're more dehydrated, you just need to drink more. So then that's the second one. Same mechanism.
Then you've got unexplained weight loss, again, because you're not using insulin effectively and not using the glucose, etc. That can lead to weight loss. You've got tiredness, again, because you can't use the energy as appropriate. And then you've got recurrent infections, which is common in women, mainly. It's normally like urinary tract infections, isn't it?
Yeah, you can also get things like thrush. That's a big one.
That's a big...
Yeah. So I think there's... if you're working in a community pharmacy and you get a woman coming in for, like clotrimazole to treat like thrush, if they're over the age of 50, I think you're not allowed to give
in a PGD, etc. And you would normally refer them.
Yeah.
There is one symptom that I didn't know, and I've had to look how to pronounce it. So it's acanthosis nigricans.
Nigricans.
Yeah, nigricans.
Nigricans, yeah.
Go on, you explain it.
It's just it's a skin condition, and it'll manifest with like dark folds in like your elbows. It can be like in just in skin folds, isn't it?
Yeah.
Any skin folds, and it can indicate insulin resistance. Again, though, it can be different things that can cause that. So it's all putting into like perspective of what it could possibly be, but that is a symptom. And then the last one is blurred vision. So that was actually the symptom that you said you got.
I got that when I was young. Yeah, I was 10, and I got obviously genetic diabetes, mouldy. But yeah, that's one thing that led me to a diagnosis. I need to double check with the actual testing process because I was scarred for life with the amount of blood tests I went for. But I don't think they knew the type of diabetes I had at the time. Because this goes on to nicely onto the next part, which is diagnosis. So in terms of blood tests, we can look for two things. There's HbA1c, which you've said, which is glycolated hemoglobin, which is where glucose attaches to the red blood cells within the body, basically in the iron part of it. So we can't use these in patients who are under the age of 18, and there are a few patients where the results wouldn't be accurate. So it's those who've had blood transfusions, anemias, HIV infections.
Anyone with an infection, I think. Well, you have to be careful about interpreting it if you've got an active infection.
Pregnancy. Just delivering a baby.
Yeah.
There's quite a few. Well, I didn't actually know the extent
to be honest.
of the criteria of when a HbA1c is invalid, technically.
Yeah.
But if we do a HbA1c, because it's tied to your red blood cells, ideally we do it on a 3 to 6 monthly basis, because that's, on average, it's 120 days, the red blood cell. And then obviously in people who've got, like, I don't know, splenectomy, it might go down to 90 days. But yeah, that's how we interpret it. And it's a value of 48 or more.
Yeah.
Is classed as diabetes.
Yeah.
And then you've got 42 to 47 is the pre-diabetes.
Yeah.
But that's the value that you'd look out for.
Then you've also got a fasting blood glucose of 7 or more. So obviously you haven't eaten, and then you have to get your blood taken then. So I don't know whether do they tend to do that much anymore, the fasting blood
That's
glucose?
how I was checked. Yeah, I had quite a few of them. And mine was coming out to, I think, 6.9.
Yeah, so yours just
So they were wondering, because of my age as well, 10, they were thinking, is it type 1? And they kept on getting me in and kept on checking me. And then you have to do well, I don't think you don't do it for type 2 diabetes anymore, but oral glucose tolerance test.
You said it was horrible.
Yeah, just basically water beforehand, and then just added with, I think, like 8 tablespoons of sugar in a small little white cup that you make the teas in, and it's a nightmare. Then you test again to see response. But yeah, fasting blood glucose of 7 or more is diabetic, or a random blood glucose of 11.1 or more. Now, ideally, in an ideal world, you would repeat these, and I would anyway as a clinician. I'd repeat them. The fasting blood glucose or random, I'd do that. I actually don't know the time scale you would repeat it in.
I know you did say this, but
in terms of its effect, you could do it day to day. It's just a HbA1c that you couldn't really recheck within a 3-month period, as we just said.
I think what in practice, what usually tends to happen is a HbA1c would be the way that we would diagnose it, really, because it's like a very common blood test that we would do. So that's how a lot of patients will get picked up, is what I'm trying to say. Yeah. Unless you've got symptoms, then you could obviously do the other ones, and then what usually will happen if it's raised, obviously if it's too high, then there will be an intervention and medication will probably be started. But if it's, say, 48, it's usually, you'll inform the patient, and then it'll be like, this is...
See if it's lifestyle medication.
Yeah, and then it'll be repeat in 3 months' time, which is what usually happens in general practice, isn't it?
And that's something to note as well, in terms of your blood glucose can be raised in periods of acute stress, like we said the other week, medication. So it's not an actual endocrine disorder all the time.
Yeah, and that's why we just said then, if you've had an infection, you shouldn't really be interpreting HbA1c at that point, because it could have been raised because of that. Also, like we've just discussed as well, if you're on medication, have you just said that? Did you just say that? If you're on medication, your HbA1c would go up, and if you were to take that medication away, it could normalise, and so it was just induced by that drug. So, but that's all like things to think about.
Yeah, and I think that is everything we wanted to discuss in this week. We are going to go into treatment of type 2 diabetes, but I think the biggest thing is, if you do have any symptoms like that, like everything that we advise, you should always see medical advice. Yeah. But it's just to draw your attention to how serious a condition it is, despite how many, 4.4 million people having diabetes in the UK just dilutes the fact of how serious a condition it is.
Yeah, and like we say, it's rising as well. It's not a condition like certain cancers where we're being able to not treat it better, but we're able to detect it earlier and earlier so that it can be prevented. This is increasing in its prevalence. So that's another thing to sort of note, that especially with it being related to diet and lifestyle, we will discuss next week of maybe what the most optimal exercise regimes are or diet plans are for the treatment of it. But yeah, I think the biggest thing that we wanted to get across was the seriousness of the condition if it's not well controlled, and that it is preventable or it's reversible.
And more research is being pumped in every year. Millions of pounds, I looked at it before, I keep going into diabetic diagnostics and management.
Yeah.
And making it more of a compliant treatment regime as well.
Yeah, I think one of the actual NHS long-term plans is to do with diabetes. So
it's got to be 10% of the budget spent on it. I mean, I don't even know what that figure is now. That was 2 years ago, wasn't it?
It is a priority for the NHS, and so hopefully, with more education for both clinicians and patients, we can sort of, we can start to tackle it.
Yeah. Well, like always, if you've listened to our podcast or watch us on YouTube, thanks for tuning in.
Yeah. And if you have any other topics that you'd like us to discuss, or if you have any questions about today's podcast or any other podcasts that we've done, then obviously just drop us a message on Instagram. And yeah, thank you for listening.
Thank you.